Hello everyone. So in this video we are going to discuss the planning of flaps, planning of reconstruction with relation to pressure source. This is the second video in the series of pressure source. In the first video we have discussed about pre-operative evaluation. So here we will discuss about the debridement and flaps, how to plan, which flaps to plan, and potential problems encountered. So the first and most important thing before we consider a flap is the debridement. Our debridement must be absolutely thorough. We should be able to remove the devitalized tissue and more importantly the biofilm which is formed over the pressure source in almost all the cases. Then we have to do sensitivities in terms of qualitative and quantitative cultures, give antibiotics accordingly. So a point to make here is regarding the debridement in ischial pressure source. Now what happens is if we debride both the ischial pressure source, the weight of the patient in a sitting position is transferred to the urethra and it can lead to urethro-cutaneous fistulas. So debridement in ischial source should be done with due caution and precautions. Now coming to the flaps proper, we will first discuss advantages of muscle flaps, disadvantages, fasciocutaneous flaps, advantages, disadvantages, and then we will discuss the general principles. Now benefits of muscle flaps are it obviously provides bulk to eliminate the dead space. In those class 3, class 4 pressure source which have got a significant dead space, muscle flaps tend to fill in that. Then they are a reliable carrier for the blood supply of the overlying skin. So by that we mean the myocutaneous flaps. Then being bulkier, muscles also tend to give cushioning over the pressure bearing areas. And superiority in infection control of muscle flaps over fasciocutaneous flaps is debatable. Now there are multiple studies which have shown that fasciocutaneous flaps do tend to have good infection control as compared to myocutaneous flaps. The blood supply in both the flaps tends to peak in around 24 hours or so, and after that it's almost the same. So superiority in infection control, which is conventionally considered to be a positive point of muscle flaps, is debatable. Now the drawbacks of muscle flaps, why muscle flaps are not commonly used, is because muscle is less tolerant to ischemia than the fasciocutaneous flaps. The pressure results in hypoxia. So initially, even if we have given sufficient amount of bulk, the pressure leads to hypoxia and rapid atrophy of the muscle. Then intraoperative blood loss is significantly higher in muscle flaps. It diminishes further reconstructive options, and most importantly the function of the particular muscle is lost. So muscle flaps are a big no-no. It is rather a contraindication for those patients who have function left, who are ambulatory, who are not paraplegic. So in those cases muscle flaps are not to be used. Now coming to fasciocutaneous flaps, when we plan a fasciocutaneous flap, what is specific for pressure sore is that the circumference of our flap should be very large. So it should be at least 5 to 8 times that of the defect, width of the defect, because we need to re-advance those flaps, and as we all know pressure source has got a very high rate of recurrence. So maybe once, twice, thrice, as many times as possible we should be able to re-advance and reuse this fasciocutaneous flap. Now during harvest of the fasciocutaneous flaps, it is important that we spare the perforators at the base of the flap. So rather than doing a conventional fasciocutaneous flap, it is better that we identify the perforators in the flap and try to preserve them as much as possible. Now this specific point is not commonly addressed, whether we should do a superiorly based fasciocutaneous flap or a inferiorly based fasciocutaneous flap. Now in patients where sensations are intact, it is always better that we go in for a superiorly based fasciocutaneous flap because again the sensations of the flap are maintained. Now we are talking of a scenario when both the flaps are optimally planned or can be used optimally for a particular defect. So in those cases superiorly based flaps are better because they are sensate flaps, and we are using them for pressure source, and since being sensate flaps, they probably are going to be more resilient, more resistant to recurrence. So that is why superiorly based flaps are more important, or rather more useful, or should be used more than the inferiorly based flap in patients with pressure sores. Now, these points we have already discussed as compared to the characteristics of fasciocutaneous flap versus those of musculocutaneous flaps. But few points for the sake of revision and stressing it more is the superiority of infection control is equivalent in both the fasciocutaneous flaps as well as the myocutaneous flaps. Further reconstructive options are not diminished in fasciocutaneous flaps. We can always advance or reuse those flaps, but we can't use the muscle flap time and again. And I think those are the only 2 points which I would like to again stress over here. Tolerance to ischemia is more in fasciocutaneous flaps, and in myocutaneous flaps it is lesser. Now coming to decision making of flaps in paraplegic versus ambulatory patients, as we have already discussed. In ambulatory patients, under no condition we should use a muscle flap. Even in paraplegic patients, muscle flaps are to be used only when fasciocutaneous flap options are not available. First choice should always be a fasciocutaneous flap, because as we have discussed, even if we use muscle flaps for their ability to provide bulk, it tends to atrophy very rapidly because of pressure. The ischemia because of pressure is also very high in muscle flaps. So muscle flaps are not a good choice for bed sores. Only when fasciocutaneous flaps are not available, then we can consider, or we should consider, muscle flaps. Now, role of skin grafts is very limited in pressure sores. Only those patients who are ambulatory and sensate, the bed sore is very wide and superficial. In those cases, skin graft can possibly be considered. And even in ambulatory patients, if we give it some time, if we optimize the patient in terms of nutrition, most of the pressure sores tend to heal and contract rapidly over a period of 2 to 3 weeks, after which we can take a decision whether we need to do a skin graft, or we permit for the wounds to heal by secondary intention. So it is a very skin grafts have got a very limited role to play in pressure. Now, regarding the general principles of flap reconstruction, so these principles are the general principles which we need to follow. We should use large flaps that can be re-advanced. So considering that pressure sores have got a very high recurrence rate, this is very important. We should avoid burning of bridges. This is the general plastic surgery principle, but it is even more important in pressure sores, because on an average, I would say almost 90 to 95% of the pressure sores in patients who are paraplegic, where post-operative care is not adequate, they tend to recur. So we need to think of our bridges of the second, third, and probably fourth reconstructive option while planning. Try direct closure of the donor site, avoiding skin graft. So if we have planned a large enough flap, the pressure or the tension over the suture line is distributed adequately, and we can almost always get a direct closure of donor site if the requirement of the flap is smaller. But we should avoid skin graft, and if at all we use skin graft, it should be away from the pressure bearing area. Then again, we should ensure tension free closure, especially because these patients tend to have some amount of spasticity. Although we make sure that the patient is free of spasticity preoperatively as well, by use of baclofen or some other interventions, tension free closure is very important in pressure sores, because some amount of spasticity does remain. There might be relapse, recurrence of spasticity. So these things need to be considered. Then we need to keep the drain for a longer period of time, conventionally longer than what we tend to use generally, maybe around 10-12 days or so, possibly 2 weeks, depending upon individual patient requirements. That is because we want to avoid shearing of the obliterated dead space and seroma formation. So the suction drain tends to avoid or sort of minimize the shearing of the obliterated dead. So in brief about the intra-op and post-op principles, Radical debridement of the cone is the key tissue. Osteomyelitic bony prominences must be removed before any flap is planned. If there are multiple pressure sources, what should be done? Now, if there are multiple pressure source and if we are able to position the patient adequately in a post-operatively in a adequate position which is going to give us offloading of the patient, and the donor sites are different, then we can definitely cover multiple pressure source in the same surgery. We don't want to give repeated surgeries time and again. Fasciocutaneous flaps, as we have discussed, have many advantages and are definitely the first line of reconstructive option. Muscle flaps are a big no-no. Only in exceptional cases we can possibly go ahead with the use of muscle flaps. Skin grafts again have a limited role, especially in sensate and ambulatory patients. So, just a quick take-home message: if a pressure sore is getting worse, it is certainly not the time to attempt closure. It is a time to debride the wound. It is time to nutritionally optimize the wound. And once the patient is better, then we can possibly consider closure in terms of a flap option. So, thank you for watching.